Welcome to another episode of The Brand Called You, a podcast and podcast show that brings you leadership lessons, knowledge, experience, and wisdom from thousands of successful individuals from around the world. I'm your host, Ashutosh Garg, and today I'm privileged to welcome a very accomplished doctor from the medical profession from Bangalore, India, Dr. Rajani Bhat. Dr. Bhat, welcome to the show.
Thank you for inviting me, Ashutosh. It's a pleasure to be here.
Dr. Bhat is a consultant and in interventional pulmonology and palliative medicine at the Sparsh hospitals, Bangalore. She's very passionate about public health. She's been involved in healthcare advocacy through the End of Life Care in India task force, which is illicit. So, Rajani, before we speak about pulmonology and palliative medicine, tell me about your own journey and what made you decide to specialize in these areas.
Ashutosh, I was just in Bombay over the last weekend, and it was a wonderful nostalgic trip because I was at a meeting at Tata Memorial Hospital. I started my medical education in Bombay in Lokmanya Tilak Municipal Medical College, General Hospital, public hospital of the Bombay Municipal Corporation. And then in our batch, we had this rule about going into serving the government in rural areas for 1 year before we start our postgrad education. And I did my 1 year of rural service in Khed, near Khed, and came back to claim what I had chosen as my profession, which was radio diagnosis and radiology at Tata Memorial Hospital. So that's where I began my journey. 1 year into that, I realized that the 1 year of rural service, where I was a family medicine community doctor, had given me a greater calling towards towards clinical medicine rather than radiology. So I changed tracks, moved to internal medicine, and then pulmonary and critical care, pursued a residency and fellowship in the US. And then soon after my fellowship, literally 7 days after my fellowship, I moved back to India and started practice in Bangalore in interventional pulmonology, training with one of the thought leaders of the field in India. And a few years into that, one realized that, this sense of technology being able to solve all the problems, at some level, you also get a sense of helplessness because disease, aging, all of these are problems that one cannot solve with technology alone.
Right.
And one gap that I was noticing in many healthcare systems was the lack of trained palliative medicine professionals. I take care of patients with chronic respiratory disease. So the unmet needs and the feeling of helplessness that leads you to pursue further training to be able to serve that need. And that's what brought me to palliative medicine.
Very well said. Very well. And this is actually a huge, huge demand because palliative medicine is something which not too many people are aware about. So now moving on, let me ask you that how has the field of interventional pulmonology evolved since the time you started? And how is technology playing a role in this area?
Oh, it's a fascinating field, and it's exploding with innovations in interventional pulmonology. When I started my fellowship, and that was in the US, there were fewer than 10% of programs across the US which offered interventional pulmonology. So even in other parts of the world, say 15 years ago, there weren't too many training programs in interventional pulmonology. The field has undergone exponential growth over the last 25 years, I would say.
Right.
Though the origins are in, decades ago. But what has really changed the field dramatically is a lot of work in navigation systems. So the ability to reduce the size of our instruments and increase our reach of being able to visualize things within the airways and finding ways of mapping and allowing us to reach the smallest of lesions in the lungs and the airways. That's been where technology has really played a huge role in improving our access to what we thought were unreachable areas of the body, unreachable safely. And I think that is going to continue to grow. So we will be able to reach smaller and smaller little tumors and nodules, detect conditions much sooner than we could earlier, and offer better treatments with that.
Well said. Well said. And how do you take a decision on when one of your patients needs an interventional procedure versus a more traditional approach?
So I think where we are moving to, Ashutosh, is about using combinations of modalities that are available to us. The decision about interventions is always one where we think of the risks and benefits and weigh those out and look at alternatives. In a resource limited country, in a lower LMICs, our approach to many of these things is different from in the Western world, because we also have certain confounders. Not everything that shows up on a scan is a lung cancer. Here we have to think of tuberculosis as well. So our decision-making process is slightly different from the traditional approach in the West. We still think of using non-invasive approaches first, and then using an interventional approach if that is going to give us the maximum yield for a patient. What is heartening is that a lot of teaching institutions across the country are now offering interventional pulmonology procedures and training programs as well. The advantages are that in some areas, our patients are then able to have their procedures, removal of tumors done without a thoracic surgery, which can be quite a painful and difficult procedure. Again, we have a shortage of trained pure thoracic surgeons in our country too. So having both modalities is very essential, and having collaboration between ENT surgeons, interventional pulmonologists, and thoracic surgeons is finally what's going to give the patient the best outcome.
Great response. Thank you. So let me talk now about palliative care. And for a lot of my viewers and listeners, help me understand what is palliative care, and how can you clarify a broader role of palliative medicine? Because it's not just end of life.
Absolutely, Ashutosh. This is one of the greatest misconceptions that we face and work with in our day-to-day practice. Palliative medicine is it's a field of medicine, a specialization which has evolved, I think, over the last 40, 50 years. And the goal initially came from wanting to provide comfort and dignity at the end of life. But the broad principle is it's a field of medicine where we are trying to offer relief from all health-related suffering for any patient and their family members who are faced with a life-limiting illness. So any life-limiting illness, which is going to change your quality of life, will cause certain stresses on your physical, mental, psychological, spiritual, financial condition. And palliative medicine is that field of medicine which looks to address all the health-related distress that a patient and their family go through, right from the time of diagnosis towards the end of life, and even after that in bereavement for the family who has lost a loved one. So it's a very comprehensive approach which takes the patient and the family as a unit, and looks to build a supportive community around the patient who's going through.
Well said. And Rajani, how does palliative medicine interact with interventional pulmonology?
That is my area of specific interest.
Yes.
I think what we do, though it seems like they are two opposite ends of the spectrum, most people think of interventional pulmonology as high tech, low touch, and palliative medicine as high touch, low tech. The goal in the end is that a patient must be relieved of all symptoms as much as possible. So if we think of it in that way, interventional pulmonology is a field where I use minimally invasive methods in order to relieve an obstruction in the airway endoscopically, and allow a person to breathe easier. So my primary function here is palliation, or removing fluid from around the lungs and allowing them to breathe comfortably without pain. Again, my goal is palliation of symptoms. So the primary goal is palliative. And that's why sometimes we call it endoscopic palliative medicine. That's what interventional pulmonology really is. I think the big difference is in the approach to the patient. So if we bring in the palliative medicine approach, where I am going beyond just treating a medical condition and saying that, oh, someone has an airway tumor or someone has a condition which is going to affect their voice box and I'm going to perform an intervention on them, then it's not just the treatment of the disease condition, but what is the patient's goal in this entire journey with a certain disease. So finding ways of incorporating the physical, mental, emotional, spiritual components, bringing in the necessary specialists to collaborate with us, whether that's a clinical psychologist or a speech and swallow therapist or a rehabilitation medicine specialist. So I do my procedure, but I also make sure that the patient has access to a rehabilitation medicine specialist so that, okay, I've alleviated the obstruction, but there's other elements of rehabilitation for them to be able to walk 100 meters, to go to the bathroom on their own. So really looking at the patient's dignity, their goals, and as a team looking to address those goals. That's where the intersection lies.
Well said. And, I've had conversations about palliative care for people in my family. As a doctor, how do you approach discussing palliative care with patients and their families?
I get referrals from for palliative medicine. My another area of interest for me is breathlessness management for patients with chronic lung disease and neuromuscular diseases. So I also practice neuropalliative care. Most people think of it in terms of oncology and pain management, but there's so much more to palliative medicine. So I think one of the challenges always is if I get a patient referred to me too late in the trajectory of their disease, then it is not, I don't have enough time to get to understand the patient and their goals. And at that time, my job really is to speak to the patient and their family that I know that you're going through a very challenging time. My role is to try and decrease any amount of distress that you are experiencing. However, when I have a patient referred to me early in the trajectory of the disease, that's when we can make a lot more happen in terms of preserving quality of life over time. So luckily, I do have colleagues who will refer patients earlier in the trajectory of the disease when they're just starting to see that their quality of life is going down. And then I have a lot more room to work with to understand what a patient's goals are, the family's goals are. And what I try and incorporate into our conversations is that palliative medicine is in no way an approach where we are saying we are giving up on treatment modalities. Being an interventional proceduralist and a palliative medicine doctor, I understand that there are interventions and procedures and technological advancements that we can use even when a patient does not have a curative option available, that all curative options have been exhausted, but quality of life is important. And whether it is something which is an expensive procedure, if that's what the patient wants, if that's according to the goal that a patient has. The patient might have a goal that I want to be around for my daughter's graduation. And therefore, prognostication becomes very important. Understand, as though though it is an inaccurate science, but we do have tools for prognostication. Having honest heart-to-heart conversations. These are not easy conversations. Most people shy away from conversations about mortality. But when you work with patients who are going through severe disease, you realize that they are actually seeking and craving honest conversation for someone who will speak to them honestly to their concerns and say, I understand. And let's talk about what you want to accomplish in the limited time that we have. And that's when we can start moving towards making those goals come true.
Said. Great response. Thank you. My next question is that how do you balance the technical aspect of your job with the emotional and psychological demands, especially when it comes to palliative care?
I think one of palliative medicine is a field which does take an emotional toll on us because we get so deeply involved with our patients and our families. That being said, one very important thing is you can't build a wall. Very often, people think that physicians learn detachment from their patients. Now, if you detach yourself from
How do
the
you cure them?
tears and the emotions, then you also detach yourself a little bit from the joys.
Right.
So any wall that you build between yourself and the patient will block the positive as well as the negative. The
Right.
only way of coping with this is ensuring that you are doing enough to address your own emotions, your own health. You can't give from an empty cup. So you must take care of yourself and your health as well. One of the doyens of palliative medicine, Dr. Robert Twycross, once spoke to a lot. He was addressing the Indian Association of Palliative Care students. It was a large gathering of people online where he was sharing 50 years of his wisdom from his research and his experiences. And a young MD student asked him, like, how do we deal with burnout? And he said, it's not a question of if you will burn out. It is when, and it will happen multiple times in your career. So the
Right.
important thing is to acknowledge that we are human. We will face burnout. Recognize the signs early and build a supportive community at work around you, which can help you through that time of burnout and refuel yourself to come back with energy for your patients.
Well said.
Yeah, acknowledging it is very important.
I agree. I agree.
And
In fact,
whatever that is, whether it's your family, gardening, music, reading, one has to take care of the physical and the emotional aspect of
I
yourself as a
completely agree.
caregiver.
Completely agree. Well said. And are there any ethical dilemmas that you face when you are talking about palliative medicine?
I think we face ethical dilemmas in all fields of medicine in India, whether it is interventional pulmonology or palliative medicine. We are a resource constrained society. And there is a huge chasm between what you aspire to do, your intentions for providing the best care for patients, as opposed to what may be available to you. And that could be because of where you are geographically, or it could be because of what's available at your institution, or it could be because of the patient's financial resources or
Right.
social support systems. So there's ethical dilemmas that come up on a day-to-day basis. In terms of one of the areas where I used to find myself in a lot of conflict earlier was around decisions around the end of life in ICUs, and there has been a huge advocacy movement by the End of Life Care in India task force, which was professionals from neurology, critical care, legal experts. And the recent Supreme Court judgments have helped us to simplify the process. A lot of doctors in India were operating with a sense of fear of speaking about death and withdrawal of life support or withholding life support, especially in critically ill patients. The recent legal advancements that have come are very reassuring and promising. It may not be everything that we hoped for as medical professionals, but simplifying the process of decision making with the support of the law will strengthen a lot more doctors' resolves to be able to have a more humane approach to the end of life in critically ill patients. So those are the ethical dilemmas. I think with the new advances that are coming into our medical school curriculums as well, which approach, there is a concept called ATCOM, which is attitude, ethics, and communication. So we're now starting to recognize the value of early training in ethics and communication in medicine. We were a young country looking at technical advancements and technical know-how being the most important thing. And things, the niceties, the humane aspects got left behind a little bit. It's time to bring back the humane touch early on in our training.
Yep. Yeah, very well said. And, in fact, one of the things that we did about 20 years ago was to add a document called a living will to our will. Because one of the biggest challenges everyone faces, the family faces, is when you are on your deathbed, nobody has the courage to take a decision. So we said, let's write it all down, what we would like it, even though it's not legal, but at least our thoughts are available on paper.
That was such a wonderful thing that you've done, Ashutosh. And I have to say that it gives a lot of comfort to family members in that situation. I was very fortunate that my parents have had open discussions about mortality with me for the last 2 decades, from the time that I was a trainee in my fellowship in critical care, they saw me working with patients with a lot of these ethical dilemmas at the end of life. So they were very open and communicative with my sister and I. My father passed on last year, but he had made his wishes known. So there was this comfort and solace in knowing that everything he did was respecting his wishes. So
Correct.
if more parents, if more people have conversations with their loved ones about what they think is a good death,
Yeah.
we celebrate birth, we
Yeah.
talk about it and prepare for it so much. Each
Mm.
of us is going to face our mortality. And if we started these conversations earlier on with our loved ones,
Right.
it would ease the end so much, and it would allow. Well, there's always grief. Right? There is
Absolutely.
sadness and grief, but it is also with this degree measure of comfort that everything was according to the loved one's wishes, and it becomes a celebration of a good life for many people.
Correct. Correct. Well said. And I have time for one more question, and I'm going to ask you to look into your crystal ball. And I'm going to ask you a question that, given the amount of experience that you have, when you look into your crystal ball, how do you envision the future of interventional pulmonology and palliative medicine in the next few years?
I think one of the we've seen interventional pulmonology exploding across the country with advanced diagnostics and therapeutic procedures being available in many, many cities. When I moved back to India after my training, there were a handful of centers. And now we have interventional pulmonology centers in not just tier 1 cities, but in tier 2 cities as well, and many, many training programs. So I see the reach of interventional pulmonology advancing. And I see a lot more training programs coming up. We've now got simulation labs and training centers in many parts of the country. So using technology to democratize access to learning is what I envision for the future of interventional pulmonology. The second thing about palliative medicine is I hope that the patient community makes a strong demand for it. At the national health level, the NHSRC and many bodies have recognized the need for greater access to palliative medicine in our national health programs. The thing is that in India, 80% of healthcare, well, 70 to 80% of healthcare is private healthcare, and the corporate healthcare system has not yet responded to the need for palliative medicine. So, if the patient community is now going to start asking for palliative care, I envision or I hope to see palliative care and palliative medicine becoming an essential department in every hospital, just like the emergency medicine department. You couldn't imagine a hospital without an emergency medicine department. You shouldn't be able to imagine a hospital without a palliative medicine.
Very well said. Very well said. And on that note, Dr. Bhatt, let me just say thank you so much for speaking to me about your own amazing journey. Thank you for talking to me about interventional pulmonology and palliative medicine. I learned many, many new things from you today. I loved your one comment, which is that you cannot give from an empty cup. That tells me so much about your own thinking as a highly respected doctor. I also appreciated your conversation about planning to talk about end of life with children. And you're lucky that you had parents who spoke to you about it, because I think that is what really changes the perspective in the eventuality which is going to be faced by every single human being. Thank you for speaking to me, and good luck to you.
Thank you, Ashutosh. Thank you for inviting me to the Brand Called You's conversation.
Thank you. Thank you for listening to the Brand Called You videocast and podcast, a platform that brings you knowledge, experience, and wisdom of hundreds of successful individuals from around the world. Do visit our website www.tbcy.in to watch and listen to the stories of many more individuals. You can also follow us on YouTube, Facebook, Instagram, and Twitter. Just search for the Brand Called You.